Hello, this is Isabel Galliano from the Cancer Coach. At the Cancer Coach, our mission is to support cancer patients throughout their healing journey. We support cancer patients with nutritional therapy, with sleep habits, with lifestyle changes, with stress management, and also with emotional well-being. And the topic of my talk today is immunotherapy. How does it work, and how does it work to treat cancer patients? My guest today is Dr. Perez. He is the medical director and founder of the Immunotherapy Institute in Tijuana, Mexico. Thank you very much, Dr. Perez, for joining us today.
Thank you, Isabel, for the opportunity and the invitation again to be here, part of the Cancer Coach series.
Most welcome, Dr. Perez. And you know, this is a topic that gets more and more attention, immunotherapy. And I can see, you know, in my daily interaction with my cancer patients that many patients still don't really understand how immunotherapy works and also if that could be an option for them or not. So I'm very happy to have you today to clear all these questions. So if you would like, please, to start just by explaining us what is immunotherapy and how does it work?
Well, immunotherapy, and specifically talking about cancer, because I think it's important for us to mention that immunotherapy, it's not exclusively for cancer. We have also immunotherapies for other diseases, such as, for instance, autoimmune disorders, which is a very different thing. So we're going to talk about immunotherapy aimed in the oncological area or for cancer. And the goal of immunotherapy, as the name says it, which is a mixture of two words, immune system treatment. We're treating, or we're making use of the natural ability of the immune system to fight disease, in this case, cancer, to be able to increase the work by the immune system, or as sometimes is the word used, to boost the immune natural defense to fight cancer. And for this, we use substances made sometimes by the body or in the lab to improve how the immune system works to find and destroy malignant cells.
So, are there different types of immunotherapy specifically for cancer patients?
Yes. This is an enormous topic and universe of information. And I think it's important to make a parenthesis, if you don't mind, because I hear a lot of patients using the argument of my immune system can take care of everything, so therefore it can save me for any kind of problem. And I think right now we're hearing about this in relation to the pandemic. Immunotherapy is ancient, the use of hot compresses or controlling fever, or the actual mechanism of fever could be seen as the principles, let's say, of what we now have as immunotherapy, helping the immune system, pushing the immune system to fight. And but it's also important to understand that we are already from the top explaining that the immune system needs help, because it cannot fight cancer by itself. So we need to break this misconception that when we have the disease, that my immune system can be boosted somehow naturally and is going to be able to respond against cancer just somehow or magically. That's not the way. And the same thing happens with many things in our environment, specifically viruses. We still have many viruses that the immune system cannot fight and not deal with. Something very simple that I don't think we're going to have debate: HIV. Right? HIV, it's a big problem. Hepatitis B, hepatitis C. So my immune system still requires help. And this is where immunotherapy comes from. So yes, talking about the different types of immunotherapy, we have, for instance, monoclonal antibodies, which are antibodies produced in the lab. These are medications that can target, or imagine they can pinpoint a cell, a malignant cell, so my immune system can go after it better. We can also discuss or have something called checkpoint inhibitors. And checkpoint inhibitors are mechanisms that the immune system has to not get too wild. You see, the immune system also requires control. So it can become too wild and attack us. So there's mechanisms within the body in check in order to avoid that. And one of these treatments involves removing that brake, as I mentioned, so my immune system can now work very aggressively against cancer. So these checkpoint inhibitors actually remove those brakes just to be able to fight, in this case, malignant cells. Then we have some viruses that have been transformed in the lab to be able to fight cancer, specifically the herpes virus. The herpes simplex, this virus has been transformed. TVAC is the most common name that you can find it. Another possibility is, I think, what patients are mostly now in contact with, which is T-cell therapy. The actual use and manipulation of the actual T cells of the patient. The T cells are the most important cells within my immune system in charge of the fight against cancer. These are, I call them the special forces of my army. My army is my whole immune system, but it's not all of it responsible for destroying the malignant cells. This responsibility comes down to a very specific or selective group of cells known as the T cells and other cells. I mean, the T cell family is also big. But just to make it simple, T cell therapy involves taking the cells, enhancing them in number to billions of cells. In our case, we're talking about 7 to 8 billions of cells, and then presenting to them the actual information of the malignant cells, which is the step that has been missed. What is the reason why my immune system is not being successful at fighting the disease? Is because my immune system can override some of the systems that my immune system hide, can change itself genetically, can change itself in the surface, can hide from some of these mechanisms. So that's, in this case, how my immune system can be fooled in a way. So again, coming back to the treatments is helping through the modification of the actual immune cells, presenting the enemy so we can activate, in this case, the immune response. And we also have something called immune modulators. Immune modulators are substances that the immune system creates or produces that we now can extract and also produce in the lab, and we can use to ignite part of the immune response. Examples, just to get a little bit technical: interleukins, interferons. Now, before I continue, and I forgot to mention this, I apologize. The immune system activates itself through messages. When I was studying medicine, I remember this very clearly because it was a little bit confusing, or not necessarily confusing. It's just that everything starts with, let's say, me pressing a button, and then this button, something reacts that it's going to press another button, that is going to press another button, and that's why we call it the immune cascade. It's a cascade of reactions in order to reach the specific activity that the immune system is required to perform against whatever it's dealing with, because my immune system can help me against anything. So in this case, the immune modulators are a little bit of the buttons that I can use to change or to increase functions of my immune system, and therefore also disease. So those are, I will say, the most important ones. And also cancer vaccines. Cancer
That was my
vaccines,
question.
cancer vaccines by definition don't exist because we're not necessarily vaccinating somebody against cancer. Vaccines are used as a preventive measure. Here it's for treatment. And what we're doing is using the principle behind vaccination to, in this case, apply this in the medical practice of cancer management. What we do with cancer vaccines is we can take the actual antigens from the cancer, or the information from the cancer, and grab that information from the actual patient. Sometimes we can use other patients or information from other cancers in order to activate immune response or create what we can define as a vaccine. Here we also enter into the area of something called dendritic cell therapy. The dendritic cell is part of my immune system. It's a cell that presents. It's a cell that goes after the enemy and says to my T cell, "Hey, T cell, this is who we need to go after. This is the invader, in this case, the malignant, or for me, the malignant cell is an unfunctional, useless cell. That's what it is. So that's what, in this case, the vaccine ensures that my immune system recognizes and mounts again the immune response against cancer. So in summary, checkpoint inhibitors, monoclonal antibodies, T-cell therapy, immune modulators, and cancer vaccines.
Thank you. Thank you for this explanation. And then if you don't mind to explain a little bit, what are the different types of cancer that are targeted by immunotherapy? And are there some cancers that tend to react better to immunotherapy than others?
Okay. In this day and age, pretty much all of the most common cancers, and I'm talking about breast cancer, lung cancer, colorectal cancer, and even the infrequent ones, such as melanoma, as we were discussing yesterday, are being treated with immunotherapy.
Mm-hmm.
Now, in oncology, it's important to mention that we don't rely on what we define in medicine as monotherapy, one drug or one agent. We typically combine things because now if we look into chemotherapy, which I know is not the topic, but if we look into it, we have also a different mechanism of action. It works differently. So some of these agents can be combined, or with radiation, or with alternative treatments, can be combined. So the answer is it is widely used for the majority of solid tumors in this day and age. It can be used as a monotherapy, but typically it's not. We recommend, in this case, considering other therapies, because in cancer management, I explain to my patients, imagine it's like putting a tank here, and then you put a soldier here, and it's protecting our front. It's not that more is better, by no means. But again, we have different mechanisms that we can exploit and use in our advantage against, in this case, the malignant environment. So in this case, again, the most common cancers right now, yes, indeed have a benefit behind immunotherapy. So again, the most common cancers that you get every day, and also specifically when it comes to the T-cell therapy with hematological disorders is being used very widely in the States with success.
So I just wanted to quickly go back to what you said about monotherapy, and so this is part of an integrative approach. So it's not necessary that you need to give up the treatment you are doing now. Immunotherapy can add to this, can be an additional therapy to your treatment plan.
The answer is yes. It all depends, of course, what the patient is doing. Where exactly in this journey, the patient is. And in our case, and you know us, we are an institute that works through what is defined as a holistic approach. I mean, in my point of view, I don't use the word holistic. It's a patient-centered approach. I work with you. I work with each patient's situation, and we emphasize that it is just because you have a diagnosis that sounds extremely familiar doesn't mean it's the same. It is not the same. Just the mere difference of age, for instance, it's enough to create a distinction. And in this specific area, it's more complex because now we have gotten to genetics and the molecular blueprint of cancer. So we can be very specific. So more than from a general standpoint of view, of course, it can be combined. But of course, in our case, it's everything is about each situation, patient, and the necessities.
Is there a moment in the journey that is more opportune to start immunotherapy?
The protocols that have been presented in oncology around the world suggest the use of immunotherapy ahead, or in many cases after the standard treatment of care, which is chemo and radiation.
Mm-hmm.
The reality of the matter is that these medications have been designed to be used since day one. I mean, they're used to treat cancer, not to treat complications or what we define as advanced cancer. So there's a little bit of medical bureaucracy behind the implement of these treatments that has to do with each country's system of healthcare. In Mexico, we have, I will say, an advantage. We work with the three systems: social, insurances, and private. Private removes, in this case, these two other ones. I don't have to worry about the government. I don't have to worry about insurance. When I say I don't have to worry, I don't have to worry about them limiting the treatment possibilities. Of course, we have regulations as in any other country. In the law, we need to abide to the law. Everything is done to the T scientifically, but we have more freedom of practice.
Mhm.
And this allows us to use combinations, regimens that maybe have already been approved, for instance, in Germany or in another major country that has also the same kind of freedom, and they're ahead, they're already being published, used by their oncological field. We can adapt those treatments. That's the advantage that we have here in relation to that. So in other countries, again, I think the lock to be able to get to unlock the door is the system.
Okay, so if I am a cancer patient and I'm interested in immunotherapy, how do I know if I'm even a candidate?
Well, there's depending on, for instance, when it comes to T cell therapy, we can say that the majority of patients are candidates. Everybody requires their immune system to be part of this. So I think there's no way around that. But when it comes to some of the medication part of immunotherapy, we use tests to define if it's if the for instance, the checkpoint inhibitors, as we were discussing, those breaks that the immune system has, we have a test to check if the tumor has enough of it, so we can then justify the use of the medication. So there's tests that allows us to define a little bit more of the characteristic of the cancer and see who is a better candidate. Now, in practice, we have seen that even without having the expression, there's benefits. But that's where experience comes into place. But from the cell standpoint of view, the T cell standpoint of view, I can say that everybody's a candidate because we're working with their own cells. We're just helping their immune system and can be used in conjunction with whatever they're doing. And when it comes to the medication side, yes, there's a scrutiny that we follow.
Okay, thank you. So how about side effects? Because that's of course something that cancer patients worry a lot, and I'm sure that that's something that you are asked every day. So okay, if I do immunotherapy, are there any risk of any side effects?
Well, that question for me has two answers because one is the general answer that I will give if somebody asks me that, and then is the answer in relation to the way we work. So
Mhm.
the answer is there's side effects when it comes to the medications. Mostly, the cells are more gentle with the body because it's your own body. When it comes to the medications from all of them, by the way, are what we call immune activations type of symptoms. All of them are a reflection of my immune system being active. By no means is like with chemo, my hair falling down, that it's a sign of, let's say, destruction of other healthy cells. We don't have that here. What we have is just my immune system is kicking behinds, and sometimes it's kicking my behind as well a little bit. And sorry for that, but I guess it's the best way to put it. Cancer patients are going to relate to it very clearly.
Yes.
So from fever to rash to weakness, fatigue, those are, I will say, the most common. Chills, lack of appetite. Those are, I will say, the most common ones. Yeah,
So it's mainly the immune system overreacting.
yes, it's mainly the immune system overreacting to, or that we are actually making the immune system in this case overwork. So that's mostly in this case what we are seeing.
Okay. Okay. So if you would have cancer patients, who have finished their treatment and have been cancer free for a while, does that make sense to still talk about immunotherapy? Because I have, for example, clients who would say, immunotherapy didn't exist at my time. So does it bring any benefit for me to still do it now? Can it help me in terms of reducing my risk of a cancer recurrence?
No, it doesn't work that way. These treatments are for active cancers. For that, I will say we need to work more on what you have been promoting, how you open, in this case, this live stream with quality of care in relation to sleep, nutrition, everything that you do. That's really the true preventive measure. Before we need to acknowledge what we define as risk factors. We sit down with each patient, and well, before we get to that, to answer the question straightforwardly, The answer is no, there's no need to do this. If you're in remission, if you're cancer-free, you're cancer-free. What we need to continue to do is be on top of the things that we need to control. Again, nutrition, environmental issues that we can control, the psychological part,
Management.
immune system, exactly, all of those things. But previously needs to be acknowledged what are those inputs in each patient, because they differ, and that's where I see the one size fits all from the alternative side. Everybody gets the anti-cancer supplement regimen, everybody anti-cancer diet. No, again, all of the interventions need to be justified in relation to each patient's needs and situation. It's not the same to nourish a 25-year-old, as we have a lot with colorectal cancer, young patients, as it is to nourish a 65-year-old. It's just not the same. As well, it's not the same to nourish somebody that has been through a surgery, for instance, specifically digestive, that is somebody that has maybe an intact gastrointestinal system.
Yes. So we come back to the importance of individualized care and individualize every protocol, which is really which makes a big difference.
There's no other way. If we really want to move forward, we need to stop this one size fits all. We need to stop these 5-minute consults, no questions, do what I tell you. It has to stop. We're not winning the war with cancer. We're not winning the war. We're definitely moving forward with new technologies, by all means. But we're not winning the war because we want to feed everybody on the same category, and it's just not the reality of the clinical practice. Something as simple as age, as we discussed, and then you have the size of the tumor, then you have the location, then you have if the patient has high blood pressure, and I can go on and on. Let me give you an extreme example of a patient that I remember every time that I get this question. Breast cancer. She also had HIV. She also had hepatitis B. She also had cirrhosis, and all of these things were already advanced. So how do you approach that? If you don't individualize, if you don't make decisions on that patient, and you cannot forget about the rest, it's just impossible. So is the only way individualization of everything from nutrition to emotions. Everything has to be individualized.
Yes, and I love to hear that from a doctor, because you don't hear it every day, and that's exactly what we stand for at the Cancer Coach. That we really want to have this individualized approach. And I get the question every day: what is the best diet against cancer? And I always say there is no best diet. There is no one fit all. I need to get to know you. I need to get to know your cancer. I need to get to know your habits, your age. Are there any aggravating factors? Do you have any autoimmune disease? Do you have any intolerances? There are so many factors that will contribute in me being able to create a diet for you. And same is in stress management. I mean, we all have different stress triggers. It's, again, not a one fit all. And this individualized approach is what is so important as a cancer coach, that we guide the client every step of the way, and everything is individualized to their needs, to their priorities of the moment, which also, as you see, also changes. And that's also, I guess, sometimes a challenge with you, that it evolves, and then you need to adapt.
That's absolutely correct. Cancer, it's not linear. That's something that I explain a lot to our patients. Specifically the patients that are more in the numeric, or their profession is more related to numbers. I get the question, what do you see in 5 years? Yes. I mean, I get struck, I can't see too far ahead. The disease doesn't let me see too far ahead, and without testing, without really reviewing. So we don't know. That's the truth. And it is extremely important for our patients to understand our limitations. We need to be honest about that. We need to remove this ego that makes patients believe that we know everything, because we don't. So in this case, yes, it's something that definitely we work very hard to explain.
And I think that's a point that will make a patient feel really much more secure, when you have this honest relationship and this honest conversation, and saying, this will evolve and will adapt, and we will adapt with it on the way. And we don't have a magic ball, to tell you exactly how you are going to react to every treatment and how the cancer is going to react.
Yes, so I get the question, well, I want the perfect treatment. Well, what is the perfect treatment? The perfect treatment is the one that you understand and you feel comfortable performing. That's the perfect treatment. Yes. And also in relation to this linear experience, for instance, right now we have a situation, global pandemic, and we didn't envision this. I mean, when I say we didn't envision this, I mean to this magnitude. Of course, we knew that it was going to come in a day that we're going to have a airborne virus and we're going to have this type of situation. We knew about it. But what I'm trying to say is we never expected the health system to collapse. And what I'm trying to get at is how many patients are suffering with cancer suffer because all this the medical systems just shut down. There was no diagnostics, no imagery, no consults. To this day, I still read documents of patients who are having telemedicine or teleconference. They're not seeing their physician. They're not seeing their oncologist. That's a big problem. This is a
Yes.
disease that doesn't wait, or I mean, there's no disease that waits. So
Mm.
it is imperative to understand that it requires constant change based on anything. I mean, an example, I have patients that tell me, I eat this food and I feel the tumor changing. It gets hard, it gets soft, as simple as that. So yes, I mean,
Yes.
it is again a dynamic, we are a dynamic organism. And I go back to genetics, nutrition, immune system, environment, psychology. All of those factors are always present, modifying somehow, some way.
Yes, I think these are very important points for patients to understand. And I think it's always important to remind them, that it's not every cancer is the same, every person is different, every treatment will be different, and the reaction to every treatment is different, and that we can't predict that ahead, but that we will be there along their sides to adapt to their needs.
Yes, it's extremely important to again remind that these differences, because also I think that patients are tired to hear that. Everybody's different, sounds like a cliche. But the reality is that we can use those differences in the medical practice to make decisions in the decision making process. And again, to individualize. So,
And to
yes,
their advantage.
of course, to the advantage 100% for both of us, the patient and us physicians.
So let me ask you one more question around immunotherapy. So how does it work? So how is it administered?
Okay, so we have pretty much the same mechanisms that we have with the rest of medications: IV, oral, and also with, in some cases, even through the skin, dermal. Those are, in this case, the ways that we can use immunotherapy, being IV, I guess the most common one, specifically for the cells, is through IV therapy. But all of them as well, oral as well as transdermic or through the skin.
And then bearing in mind that every treatment is different, but typically how long is an immunotherapy treatment? How long does it take?
The actual administration is very fast, but the regimen, we go back to a case by case or as depending on the situation. But we're talking about a long-term treatment. At least I will say 6 months, but everything is based on evaluation, because before the 6 months, I need to stop, measure, look into the results, and see that we're heading to the right direction. We cannot ask a patient to commit to a treatment without stopping and measuring. And I explain this a lot with patients, because I hear specifically from alternative clinics programs of 12 weeks, 6 months. Where do you come from with that? That's not ethical. That's not
Mhm.
something that I can really project. It has to be a step-by-step process. I need to reach point B, and then I can maybe make the next decision making process, but not in that sense. You see, it cannot be in that way.
So I got a question here from some of our listeners. He's asking, so I am in cancer treatment now. How can I find out if immunotherapy is something for me?
Well, the logical answers will be with the oncologist, hopefully. In this case, that the person that is treating this patient should be, in this case, the vehicle of information to explore this. But I go back to, I don't know where this patient lives and what is the healthcare system. We hear a lot of, well, you're not a candidate because the cancer is not advanced. Again, that doesn't make sense. We don't do medications for advanced situations. We create medications to treat cancer. We have advanced situations, which is different.
Mhm. So it's again important to understand that every country is different and every regulations are different. So it's difficult for you to give a generic answer because it's
That's
really will vary
correct.
from
But
country to country.
the theoretically speaking, the oncologist, the physician, will be the one.
I have another question here. Does age play a role in the effectiveness of immunotherapy? Do younger people react better versus older people?
Well, I mean, yes and no. Yes and no, because of course, I mean, if you take from me 20 years, I'm gonna jump and run like I can jump
Mhm.
and run right now. I mean, that's obvious. But to say that we cannot achieve remission with a 75-year-old or 85-year-old or even 95-year-old as we do with a 25-year-old, that's not true.
Okay.
We
Okay.
can. It's just that maybe more than we need to be more careful. It's like with babies, it's just each phase of our lives represents something, physically, biologically, functionally. And I think that's what we need to tune with, but of course it can be used in all of the stages of our lives. But I guess youth continues to have an advantage, generally speaking. Generally speaking.
Okay. And then I have another question here from a lady who says, I had cancer 4 years ago. I had chemotherapy, radiotherapy, surgery, no immunotherapy, and unfortunately I had a relapse a few weeks ago. Can I consider immunotherapy now when my cancer comes back?
Well, the thing is, we forgot one piece of the puzzle. What type of cancer this person has? I presume, based on what I'm hearing, it's most likely breast cancer. And if that is to be the case, yes, of course. Again, the most common cancers: breast cancer, colorectal cancer, digestive cancers, esophageal, pancreatic, colorectal. Immunotherapy is now part of it. Again, even the non-frequent cancers such as melanoma, sarcomas, are being helped with this because those cancers don't respond to chemo. So the answer is it's something definitely to explore.
So I guess the question here is can immunotherapy be used in a secondary cancer?
It is not defined as a secondary cancer; it's a reoccurrence. And
Yes.
the question here to this patient also is, okay, typically we do chemo, radiation, surgery. I call that tumor treatment. Don't get me wrong.
Mm-hmm.
But the question for that patient is, what did we do to avoid a reoccurrence? Did somebody sit down with this patient and started to look into the risk factors and work with those risk factors as you do with your patients? Most likely, maybe no. And if that is to be the case, with all of that population of people that are working in that kind of scenario, I don't want to scare them, but most likely we're waiting for the cancer to come back because we're not being proactive and we're doing kind of the insanity definition. Because I just finished chemo radiation, but I'm coming back to the same old-fashioned way of living. No, again, we are to blame for that. All right, we are to blame.
And it's all about creating an environment that is less favorable for cancer to come back. And that's a lot also what we do at the Cancer Coach, creating the best possible environment, both physically and mentally, to reduce the risk of reoccurrence by implementing new lifestyle changes, by implementing healthy habits around food, around sleep, around stress management. And it's that aspect that now, luckily, is taught more and more, but is very, very much often absent in cancer care. It's about, as you said, just addressing the tumor, not addressing the environment in which the tumor grows, and not addressing it in future to reduce risk. And I always get very nervous, if that's the right word to say, when I hear from my clients saying, oh, my doctor just said, just go back to your normal life, just go back to your life before cancer. And my reaction is always, well, that created the cancer in the first place, right? It would make sense to look at it and see, what are factors that you can improve, what are factors that you can work on to prevent it to happen again.
Definitely. It's we need to understand that this happened for a reason. It's not necessarily the blame of the patient. I get this also a lot, and specifically because I also have patients that are cancer coaches, that are people who are promoters, even physicians, and specifically for people who are very health conscious. We get this a lot. I've been doing this, I've been doing that. I don't understand how I got cancer. And I explain, this is not a disease of people who don't behave or have a bad lifestyle. No, there's still a lot of unknowns. There's still a lot of factors that still are being studied. I see a little bit of cancer. I see cancer as a failure of our adaptive process. Our environment is changing so drastically and so rapidly, and we're adding things to the environment on top of it, that our organism maybe has a challenge to be able to adapt so quickly, when adaptation took years. It took us years to stand up, for our immune system to respond, and so on. It takes years. And again, I mean, just with what's going on with the environment, processed foods, hormones, and so on, the sun, it's too much and becomes a burden that the body cannot deal. So it's about being responsible for the things that I can control, and the things that I cannot control, well, that's called a different thing. But my point is that yes, there's a responsibility for us to help the patients identify what are those areas, risk factors, that we need to work also, and modify. Um, for instance, the most common thing that it's absent and triggers questions to patients is nutrition. When they ask the question to their physician, what are you supposed to be eating? Whatever you want, unrestricted diet. That doesn't make sense. While I was waiting, I in your website, or in your Facebook page, the previous talk was about sugar. I was listening to that talk, and again, it's an enormous topic. So nutrition is left the building. Somewhere in a given moment of our history in medicine, nutrition left the hospital, and now apparently it doesn't exist in oncology. It does. We need to be honest about what we know about the food industry, because it's a reality. By all means, I mean, there's tons of documentaries that expose this, and it's not an exposure, it's just the reality of processed foods. 50 years ago, moms came out to become the working force, and a new opportunity for the food industry of creating quick meals, that have very high concentrations of sugars, processed sugars. And that's the big problem. But the point here again is the lack of acknowledgement of these interventions as proactive to avoid a reoccurrence.
Yes, and I think that's an important point that you made. It's not about blaming the patient. It's for sure not giving them a sense of guilt. There's already enough guilt in a cancer patient mind. It's not about that. It's just trying to put them in the best possible situation and optimize their lifestyle and their nutrition so that they are in a better place. And also I feel that, and I see that with my clients, that emotionally it also has an impact. When you give them some sense of control, when they have some kind of feeling that they have a say in this journey, that they are not just completely, dependent on only the oncologist, but they also can have a positive impact, and they can, in their daily life, with every choice they make, everything they put in their mouths, the exercise they do, the way they breathe, the way they sleep, the way they manage stress, that all of this can contribute to a stronger immune system and to health. Having this kind of giving them a sense of control back, I feel is also very, very important in this healing journey.
That's essential. I mean, I'm going to offer that you invite, I mean, sorry for the intrusion, our psychologist and our nutritionist, so you can hear, because I think it grants just a topic from those two areas. Just the psychological part is a very big topic, because you hear horror stories of how patients are informed of their condition, their future steps, everything, and it's horrible. That's not empathic. That's not humanistic. That's not what we learn to be as doctors. That's another thing. Get your things. For instance, we love to do predictive medicine. Condemn patients to time. You have 6 months, 3 years. How do you know? I have patients that they told me that 4 years ago. That's not helping at all. I still question to this day, what is the benefit of saying to a patient, oh, you have 3 months? What are you gaining? First of all, you don't know, because you don't see the future. We're not clairvoyants. Experience doesn't give me the ability to see the future. Of course, I can sense things because of my experience, yes. But I have a responsibility and a duty with my patient, which is, I swear to help you, and starts with us. The first person that blocks the patient to believe that they can get better in the oncological field is us, is the physician. Oh, well, it's difficult, the chance of survival, and we start to throw numbers which are not necessarily reliable because, again, the one size fits all. Instead of grabbing the patient by the hand and saying to their eyes, let's do this, we can get better, we will get better.
Mhm.
And if something happens in the middle, patients are not going to turn back and say, you lie to me. Never
Mhm.
happens, never. They feel more damage by my indifference, or the indifference that occurs because it doesn't happen here, sorry. The indifference, the lack of empathy and love. Oh, that's horrible. And that's something that we promote tremendously, and
Yeah,
not
and
because, sorry, not because some of us have experienced this firsthand, not because of that. It's because how can I not do it? How can I
mm,
not? I'm looking at the situation, I'm hearing the situation. Mm.
and that's a conversation that as a cancer coach I have really on a daily basis. Clients who tell me a number. I have been told between 2 and 6 years. I have been told between 6 months and 9 months. I get it every day. And this becomes such a fixation
Hmm.
in their journey. And also it has an impact, a nocebo effect, like the placebo effect, it also has a nocebo effect that you believe in it and your body starts, you know, handling in a different way. And it's always an important part of my work is to detach them from this number and to explain to them, this is a number, this is statistic, this is you putting in the statistic a number, it's not you, it's just a statistic. Nobody knows. What we do know is that people who have a positive outlook, who are optimistic, who have an active role in their healing process, they do better. So let's focus on that.
So that's true. I always tell them to throw those comments to the trash. That's where they belong. They serve no purpose. They serve no purpose whatsoever. Again, it's not necessarily the case because we cannot. The experience of other patients doesn't, again, grant me clairvoyance. And again, it's important to understand that in patients that maybe are a little bit more older, 50 plus, those type of comments are going to vary them. That's the truth. Because I have patients that start to make the mathematics. Okay, I'm 80 plus. Why fight? Why? And the
Yes.
grandpa goes down. You know, so those kind of things are in this case the situations that we need to avoid in this case. Engaging again. There's no need. There's no reason whatsoever. This is about the way I explain this is we sort to be the cheerleaders. I am a cheerleader for my patients. We cheer, and again, it's a compromise, and the rest comes by itself. But yes, the mental aspect of cancer management is essential. Without it, I'm turning everything down. Even if I give you the perfect treatment, but if I'm still not giving you that reassurance mentally, it's not going to work.
Yes, and an important point that I also always make is to make sure that my client is feeling comfortable with the doctor they are working with. Because there are also studies who have shown, if you feel confident with your doctor, if you feel that he is going to really take care of you, you are in good hands, it also improves, your healing journey. And I'm always also a big promoter of go for a second opinion, go for a third opinion. If you feel that this is not right for you, you need to feel, okay, this is what I should be doing.
Yes, to remind our patients that we work for them. We are the
Mhm.
ones working for you. We work for you. I know that sometimes it's not the way it feels, but we work for you, and don't accept anything less. Many of my American patients, are very strong in that sense. Oh, I'm going to fire my oncologist, and they're right. I mean, they're right. We are the ones who need to morph and adapt to our patient's personality, not vice versa. Yeah,
Mhm.
I'm not doing you a favor by seeing you.
Mhm.
No, you're thank you for choosing me as your physician and allowing me to be part of this journey. It has to be
Mhm.
the opposite way.
Yes.
I always joke that my behavior as a doctor is like a waiter. It's the same way. I serve patients. It's
Mhm.
I use that analogy. It's the same for me. It's the same contrast. When I go to a restaurant, that's how I want to make my patients feel.
Yes, I love, the discussion we went into it. We went a bit over the topic of immunotherapy, but topics that are so, at heart for cancer patients and that are not often discussed. Sometimes we really just focus on the technicity part of it, and it's so important to bear in mind the person that is there and the emotions, and how we can, as supporter, can play a role and enhance the healing journey. And if you don't mind, just to end with what we briefly discussed yesterday, I like the analogy you made with cancer patients and alcohol and people who had alcohol problems.
Yes. So when I talk to my patients about having cancer, and I use the analogy of being an alcoholic, that even if you're sober, you need to be on top of this for the rest of your life. But this doesn't deny you a completely normal, healthy life. And you're already ahead, because all of these interventions are things that all of us should be aware of. All of us should have a clean diet or a healthy diet, exercise, mental health, be aware of the environment, improving our immune response more now than ever, you see. So these are interventions that all humans should be implementing, but it's a shame that as humans, we always act when we have the problem in front of us. So, but to our patients, it's important that they don't feel trapped in this prison that feels that forever. No, it isn't. Cancer is not a death sentence, as well as it's not a prison. But also, again, we need to help them. Again, we go back to the psychological part, because I forgot to mention that when we were talking about time, it's like placing an invisible clock that is running, that patients can't even see the time. The same thing happens when a patient achieves remission. I have patients that are in remission, and they're just lingering about when the cancer is going to come back, where the cancer is going to come back. And this is also part of the human nature, because we live in the future instead of trying to live in the present. It has to do a lot with all of those little details that create the big picture. But yes, again, cancer is like being an alcoholic, at least for us.
And I think that this fear of recurrence is definitely a part, and that's a whole other topic that I'm happy to talk with you about. This fear of recurrence is always so present, and for us also, it's always finding this balance for our clients, that they have a proactive role in their lifestyle, that they do everything they can to remain healthy, but without it being in panic mode all the time of the cancer coming back, because that also is not a quality of life. If you live in constant, it's not a nice life to live.
That's correct. And here again, part of the work that we do, it involves reminding them that we are cancer-free, that we are taking care of the other areas, so we're safe, and we're going to be with you. But it's important to enjoy what has been achieved. You see, so by all means.
And to always give hope. And that's why I'm always very open to tell my story and to remind, you can recover from cancer. I've been now 15 years cancer-free, and I do work a lot on my health. So I do really, it's a work, to be on top of your nutrition, to make sure you do the exercise, you find your moments of relaxation. But, there is a big price at the end. And there are so many stories of people who do recover and have a normal life after cancer. And I think it's important to talk about these stories too, not only talk about the sad stories, but talk about all the success stories and all the people who have gone through a very difficult time. It is a very difficult time going through cancer, but who saw the light at the end of the tunnel, like me, and enjoy life again.
That's correct. That's correct. And again, it's again coming back to this compromise of being positive, pushing our patients to move forward, and again being the cheerleaders, completely in tune.
Wonderful. It has been a great joy to have you on my talk, Dr. Perez. I'm looking forward to see you again. Thank you for all of you who are listening to us, and don't hesitate to send us more questions. Even if it's on the replay, we will get back to you. Thank you, and see you very soon.
Thank you, Isabel, for the opportunity, and thank you for the invitation. It's always a pleasure to discuss with you and Luke. So thank again for the invitation.
Most welcome.
My brain.
Yes. Bye.
Bye-bye.